Good morning, everybody. Thanks for joining us today in our Radiology Grand Rounds. Welcome, Dr. Taylor, and thank you for being with us today. My name is Lorena Telles. I work at La Cardio, and it's my pleasure to introduce to you to our moderator for this event, Dr. Juan Manuel Perez, Chief of the Radiology Service at La Cardio. Welcome, and thank you for moderating this event.
So, Dr. Taylor, thank you very much for joining us today. It's a pleasure to have you here as a speaker. As I said before, hopefully next time we'll be here in person in Bogota or somewhere else in Colombia. So let me introduce you to the audience, and afterwards I'll give you the screen so you can start your presentation. At the end, we will have some couple minutes for Q&As. Buenos días. Muchas gracias a todos por la participación. Mi nombre es Juan Manuel Pérez, los estaré acompañando hoy en la moderación de esta conferencia. Les recordamos que al conectarse a esta conferencia autoriza el tratamiento de sus datos personales, los cuales serán tratados de acuerdo a la ley 1581 del 2012 y nuestra política de datos personales, las cuales se puede consultar en la página de la carga infantil. De igual manera, les informamos que esta conferencia está siendo grabada. El chat de preguntas se encuentra habilitado en la barra de participantes. Les agradecemos dejar sus inquietudes, las cuales se resolverán al final de la sesión. Especial agradecimiento a las empresas Gebarco y GE por vincularse como patrocinadores de esta actividad. Y hoy tenemos el gusto de contar con la participación de la doctora Jana Taylor con la conferencia Imaging in COVID-19 y CORADS. La doctora Taylor hizo sus estudios de medicina en la Universidad de McGill, posteriormente su residencia en la misma universidad y sus dos fellowships en imagen abdominal en la Universidad de McGill y la parte de imagen torácica en la Universidad de Harvard. Tuve la oportunidad de trabajar con ella, fue profesora mía en abdomen y es un gusto tenerla otra vez por acá. So, Dr. Taylor, thanks again, and give you the screen so you can start your presentation.
All right, great. So thank you very much for what I hope is a kind introduction. Unfortunately, I didn't understand much of it. Dr. Perez was one of our superstar fellows in abdomen in our department back in the day. And I really appreciate the invitation and the opportunity to speak to you today. So today I'm going to talk about imaging in COVID-19 and some of the classification systems that are used in the evaluation, specifically the CORADS system, which has been devised and proposed. So the learning objectives today will be to review the acute imaging findings in COVID-19 pneumonia and how they're classified and described, and to review as well some of the reporting systems that are used in the imaging findings on chest CT. And as well, we'll spend a bit of time talking about the sort of subacute to chronic evolution of the imaging findings and what are the potential clinical implications for these patients now that we're more than a year out from the pandemic and we're starting to see some of the long-term sequelae of these patients. So a lot of the data that I found can be taken from several excellent articles. And the first was this article in Radiographics that was published in October of 2020 on chest CT and COVID-19, what the radiologist needs to know. And this is a very good sort of summary review article on acute imaging in COVID. As well, the group that I'm a member of, the Canadian Society of Thoracic Radiology, in the fall also published a consensus statement on the imaging of COVID-19. Then we'll be talking a little bit about the CORADS system, which was developed by a group of radiologists in the Netherlands. And I'll talk a little bit about as well the CT Severity Score, which is not so much a classification system, but more a method of evaluating disease severity radiographically and correlating that with clinical outcomes of the patients. So to start with, the radiographics article that I mentioned earlier classifies the acute CT findings into sort of 4 categories. So they describe either a normal CT findings that are seen in high incidence, so greater than 70% of patients who have a positive COVID test, findings that are seen with an intermediate incidence in 10 to 70% of positive COVID test patients, and findings that are seen in only a very low incidence, so less than 10% of patients who have a positive COVID test. And the CSTR classification is a little bit different. We have the same idea, but we kind of classify it as typical, which would be sort of the high incidence, non-specific, which would be the intermediate incidence, and then what we would call negative for pneumonia. So these would be sort of correlating with the low incidence findings. And I'll go through the different findings that we see in each of these categories. So starting with a normal CT, if we look at the incidence of normal chest CT in patients who are presenting symptomatically, this is actually estimated in about 10% of all patients. And obviously this is higher the earlier that the patients are presenting. So typically a normal CT can be seen in sort of the first 1 to 4 days of the development of clinical symptoms. Not unexpectedly as well, normal chest CTs can be seen in asymptomatic patients who have a positive COVID test for whatever reason. You know, if it was a mass screening or you know, screening done for other reasons. And normal chest CT in asymptomatic individuals can actually be seen in up to 46% of patients. So what we see in either the high incidence or what we call the typical appearance, again, these are findings that are seen in over 70% of patients with the COVID positive test, are the typical findings that we're all very familiar with by now. And these are the typical ground glass opacities that are bilateral, multifocal, typically are described as having a posterior and basilar distribution. So here's just an example of what we see with a typical appearance, the bilateral, posterior, basal, and subpleural areas of multifocal ground glass opacity. So the intermediate or the non-specific appearance, this is what's seen in 10 to 70% of patients with the positive COVID test, and I've kind of listed the different percentages here that are associated with a positive test. And this is kind of a very big, you know, kind of a grab bag, and you know, COVID can have multiple different appearances, but you can see areas of airspace consolidation. You can see the crazy paving pattern with ground glass and interlobular septal thickening. Other signs you can see are sort of an interstitial pattern with septal thickening and reticulation. So you can see multiple different types of patterns in sort of this intermediate or non-specific category. So here's just an example again from our own institution. This is not the typical classic appearance. There's some ground glass, but there's also sort of a crazy paving appearance here. It's a little bit subpleural, but there's also some central distribution as well. So this would be described or classified as indeterminate or non-specific for COVID. And then things that are seen with low incidence, or what we would call negative for COVID pneumonia, these are seen in less than 10% of the time. And when you see these findings in isolation, typically these findings would suggest another diagnosis rather than COVID on imaging. So these things like pleural effusion, isolated lymphadenopathy, tree and bud opacities, central lobular nodules, pericardial effusion, or cavitary lesions. So this is kind of an exception. This is a patient who has normal parenchymal findings, actually was COVID positive and is presenting with a pericardial and a pleural effusion. And this is a young patient actually presenting with COVID myocarditis. So the CORADS system was developed as sort of a categorical assessment scheme for the involvement of the lungs on unenhanced CT chest. And this was published in April of 2020 by a group of radiologists in the Netherlands. And just like any of the other RAD systems, so the BI-RADS, you know, the PI-RADS, the LI-RADS, it's meant to represent the level of suspicion for pulmonary involvement based on the imaging findings. And it's important to remember that this is meant for use in a moderate to high prevalence setting. So in an area where COVID is uncommon. I'm not sure if there is anywhere in the world right now that's like that. But this should not be applied in a setting where COVID infections are rare. And just like the other RAD systems, it's a 5-point scale. And the scale, like any of the other RADs, again, it ranges from 1 to 5, with 1 being a very low level of suspicion and 5 being a very high level of suspicion that the findings on the imaging are due to COVID infection. Just like the other RAD systems, a score of 0 just means the scan is non-interpretable. So, due to respiratory motion artifact or other technical issues, a scan that's non-interpretable would be assigned a CORADS score of 0. Any case that's, PCR positive, so a proven test, again, would be assigned a CORADS category of 6. So we'll go through the different scoring here from 1 to 5 and look at some examples of what they would be assigned. So CORADS 1 is very low level of suspicion. So this is what we would see if the CT scan was normal. The caveat being that this would be more than 4 days after the onset of clinical symptoms. So again, like I was saying before, there is about 10% of patients who are symptomatic and very early can actually have a normal CT. So we would kind of temper this with the importance of looking at the onset of clinical symptoms, because it's not reliable in the first few days. Other things that would be given a CORADS score of 1 would be CT findings of an unequivocal non-infectious process. So something like a severe fibrosis, a lung malignancy, a very typical classic findings on CT of pulmonary edema. So smooth interlobular septal thickening with associated pleural effusions with no associated ground glass opacity. You could assign that a CORADS score of 1. So here's just a couple of examples of CORADS 1. This is a normal CT, and this is very typical interstitial edema with mild interlobular septal thickening, a small bilateral pleural effusions, and no associated ground glass opacity. So CORADS 2 still is a low level of clinical suspicion, and you assign a CORADS 2 for scores for CT scans that have infectious findings, but they are not compatible with COVID-19 pneumonia. So these are infectious findings that we see with other disease entities. So a bacterial pneumonia, so a bronchopneumonia, a lobar pneumonia, anything that looks like a pulmonary abscess, bronchitis, or an infectious bronchiolitis. And then the patterns that are associated with a CORADS 2 score in imaging would be areas of tree and bud opacity, centralobular ground glass nodules like we would see with an infectious bronchiolitis, areas of focal airspace, lobar or segmental consolidation, and areas of lung cavitation. So these are both examples, both COVID negative patients who were assigned a CORADS score of 2. Here on the left, we see a patient with infectious bronchiolitis, little areas of tree and bud opacity here, some mild bronchial wall thickening. And this is a patient with a bacterial lobar pneumonia with areas of focal dense airspace consolidation with no associated ground glass opacity. So CORADS 3, like any of the 3s in any of the RAD systems, is a bit of a tricky category. It's the indeterminate or the, I don't know what this is, but I don't think it's COVID kind of category. And this is sort of the equivocal category. So these are findings that have overlap with other viral pneumonias or other non-infectious causes. So we can see ground glass opacities in COVID in the CORADS 3, but these are typically not the distribution that we would see with the classic appearance of COVID. So these would be perihilar ground glass opacities, homogeneous diffuse ground glass opacities involving both the upper and lower lungs symmetrically, areas of ground glass opacity with interlobular septal thickening, so sort of the crazy paving pattern again. The small areas of ground glass opacities that are not centralobular. So remember again, if we have centralobular ground glass, that's actually COVID-2. or small areas of ground glass opacity that are not located immediately adjacent to the visceral pleura. And we'll see in a minute that if you have ground glass opacities, they're adjacent to the pleura, you actually call that a CORADS 4. And then anything that looks like organizing pneumonia, but without any of the other associated findings of COVID-19. So you can see this is kind of a heterogeneous group of imaging findings that would be listed as equivocal or CORADS 3. And here's just a couple of examples. This patient actually was COVID positive, but was called as a CORADS 3. So there is one very small area of ground glass opacity, but it's not immediately adjacent to the pleura. So there is a bit of subpleural sparing here, which was why this was called a CORADS 3 lesion. And here we have, this was actually a bacterial pneumonia. We do have areas of ground glass opacity. They're multifocal, but there's also associated areas of airspace consolidation. And again, this is more of a central distribution. There's areas of subpleural sparing, and this patient was COVID negative. So going over CORADS 4, we almost need to talk about CORADS 5 before we can go back and talk about CORADS 4, but I'll try to address these in order. So CORADS 4 actually conveys a high level of clinical or radiographic suspicion for COVID-19 pneumonia. And these are findings that are typical for COVID-19, but still have some overlap with other viral pneumonias. And they look like what you would call a CORADS 5, except that they have a few things that are kind of missing that would make them not be a CORADS 5. So these are ones that would look exactly like typical COVID, except that they don't have the contact with the visceral pleura. So you can have multifocal areas of ground glass opacity, but they're not contacting the pleura. A strictly unilateral distribution. So all of the findings of typical COVID, but there's only unilateral involvement, or there's involvement in a peribronchovascular distribution. And they've also added CORADS 4 when you have typical findings for COVID, but they're superimposed over severe diffuse pre-existing pulmonary abnormalities. So someone who has severe central lobular emphysema or severe lung fibrosis. Obviously, we know not just with COVID, but with other disease processes, when you have a disease process superimposed over a pre-existing diffuse radiographic abnormality, it can affect your level of certainty for that diagnosis. So here's a couple of examples of what would be considered CORADS 4, and both of these patients were actually COVID positive. So here we do see multifocal areas of ground glass opacity. They do extend to the visceral pleura, but it's purely unilateral disease. So all of the typical findings are here, except that it's unilateral disease. So that would make it a 4 instead of a 5. And here again, in this patient, typical findings, ground glass opacity, bilateral, multifocal, extending to the pleura, but this is superimposed on severe pulmonary edema, pulmonary emphysema. So this kind of affects your level of certainty, or your confidence level that this is COVID. So you would rank this as a COVID 4. So still high level of clinical suspicion, but not enough to call a 5. So the CORADS 5 is the very high level of clinical of radiographic suspicion. And there's sort of 4 things that you must identify. So you must have areas of ground glass opacity with or without consolidation. They must abut the visceral pleura, at least some of them. They have to be multifocal, and they have to be bilateral. And then they talk about some other findings that you can see as well, whether it's a sharp or unsharp, this sort of half-rounded shape, the demarcation. You can have associated crazy paving. You can have associated areas of organizing pneumonia, and seeing thickening of the vessels within these areas of parenchymal abnormality. One thing I found quite interesting in the CORADS classification is that they specified that lower lobe predominance is not actually a required feature. And if we remember back in the CSTR and the radiographics article, both of those did actually talk about lower lobe predominance, but the CORADS classification doesn't actually require lower lobe predominance. So you can have sort of a mid to upper lung zone distribution and still have something be considered a CORADS 5 if it fulfills all of these other requirements. So these are all COVID positive, CORADS 5, Again, this is what I was saying about this being a predominantly upper lobe distribution, but still multifocal areas of bilateral ground glass opacity that are touching the visceral pleura. This is a case that has sort of more typical features of organizing pneumonia, but we still see bilateral multifocal areas of ground glass opacity. And then these are showing sort of the mixed ground glass and areas of airspace consolidation. So how does CORADS perform in real life when it's used in the radiographic department? So the group looked at 105 randomly selected CT chests from their ER department, and these were all patients coming in with a clinical history of suspected COVID-19 infection. And their COVID test results were obtainable and were available. And then these scans were reviewed by 8 radiologists who were blinded both to the clinical history and the PCR results. And each of these 8 radiologists assigned these cases a CORADS score. So this bar graph is showing the correlation between the CORADS score and the results of the COVID PCR test. So anything in green is a patient who had a low clinical suspicion of COVID-19 pneumonia and a negative COVID test. And the red is any case that has a positive PCR test for COVID. The yellow cases here, the yellow bars are showing patients who had a negative PCR test, but a very high clinical suspicion for COVID pneumonia. So, you know, they were wondering maybe these were actually false negative PCR tests in these small groups of yellow. So it actually performed quite well. If we look at cases that were given a score of COVID, CORADS 1 by all of the readers, 94% of those patients actually had a negative COVID test. So that was quite good. CORADS 2 category, which was still sort of low clinical suspicion, 86% of those patients would have a negative COVID test. And then if we look at the 4 and 5 category, 93% of patients with a positive COVID test were given a CORADS score of 5, and 84% of patients with a positive COVID test were given a score of CORADS 4. And then the intermediate category, as expected, 34% of them were actually COVID positive, 58% were COVID negative, and then there was a small percentage of them that were clinically likely COVID, but actually PCR negative. So it actually is quite a good discriminator between the low probability CORADS 1 and 2 versus the high probability CORADS 4 and 5, and able to in discriminating which of these patients would actually have a positive COVID test. If we look at inter-observer variability, there was absolute agreement in all 8 observers in all CORADS categories in about 68% of all of the cases. And then the other 28% of the time, there's only a difference by 1 CORADS category. So somebody would have called something a 4, someone else would have called it a 5. And in over 80% of these cases, these were still lumped as either a 1 and 2 or a 4 and 5. So they were either called low or very low probability or high to very high probability. And then in about 4% of the time, there was actually a difference in 2 CORADS categories amongst the 8 different observers. So fairly good inter-observer variability. And if we look at inter-observer agreement, overall kappa values for all CORADS categories was 0.47%. So there's sort of moderate to substantial inter-observer agreement. The best was the CORADS 5 category with a kappa score of 0.68. And then the second best was the CORADS 1 category at 0.58. And just to show you some inter-observer agreement for some of the other RADS systems, it didn't perform quite as well as lung RADS. So just looking at, in general, lung RADS score, the kappa value is around 0.67, but it actually performed better than PI-RADS, which is actually not all that great, sitting here at around 0.24 for kappa value. So I'll move on now to talking about the CT Severity Score. And this was an imaging tool that was developed by a group in China, and this was published again in the spring of 2020. And this is a tool for assessing disease severity in patients who were known COVID positive. So this group looked at 102 patients with a PCR confirmed diagnosis of COVID-19 pneumonia, and they calculated the CT severity score by summing up the individual scores for 20 lung regions. So they assigned 10 regions to the right lobe that corresponded to the 10 anatomical segments. They also gave 10 anatomical segments on the left side, just to make things equal. And so for example, the apical posterior segment of the left upper lobe, they divided into an apical and a posterior segment for the purposes of evaluation. And so they looked at all 20 segments, and each of those segments got assigned a score of 0, 1, or 2. So 0 would be no parenchymal involvement of that segment. A 1 would be less than 50% involvement of the segment, and a 2 score would be equal to involvement of 50% or more of that segment. So theoretically, you could have a score of anywhere from 0 to 40. So 0 would be no involvement, and 40 would be greater than 50% involvement of all 20 segments. And then they also divided these patients into mild disease versus severe disease based on a bunch of different clinical parameters as well. So here's just an example from that article. The top is a patient with mild disease with an assigned CT severity score of 4. So we can see, mild involvement of 4 segments here. And here's a patient with more severe disease, and this patient had an overall CT severity score of 35. So multiple segments involved more than 50%. And when they looked at finding the optimal threshold of identifying severe versus mild disease clinically, the CT severity score threshold was found to be 19.5%. So using that as an imaging cutoff had about an 83% sensitivity and a 94% specificity for determining which patients were going to have a severe clinical course of the disease. And it has about a 75% positive predictive value for severe clinical disease and a 96% negative predictive value for the presence of severe clinical disease using a cutoff value of 19.5. So that's the CT severity score. I would say personally, we haven't used this at our institution. I can see it being a useful tool for, maybe for research purposes. I wouldn't say that any of us have time right now to sit there and calculate this out for every patient that's coming through our department right now with COVID pneumonia, but it's an interesting tool to kind of predict how the radiographic findings will correlate with the clinical disease severity. So the second half of this talk, I'm going to focus on the temporal evolution of the imaging findings of COVID. And I'll talk about sort of the subacute and the more chronic phase. And then this is kind of an interesting discussion. And now that we're more than a year out, we're starting to see the chronic long-term sequelae of this infection. So in the acute to subacute phase, they kind of describe 4 classic stages of evolution of the imaging findings. So the early disease findings are seen in 0 to 5 days after onset of symptoms. The progressive disease is seen at the 5 to 8 day stage. The peak imaging findings are seen from about 9 to 13 days. And then the late stage is what develops 2 weeks on after the initial onset of symptoms. So the early stage, we can see either a normal scan or we can see these areas of isolated ground glass opacities. And again, this is the typical example. So this is what we would see in the early stage in 0 to 5 days after the onset of symptoms. And then in patients who go on to progress, we see increasing ground glass opacities, so they become more diffuse. And we start to see areas of crazy paving. So we're starting to see more interlobular septal thickening. We start to see a little bit of airspace consolidation, and we start to see a little bit of bronchiectasis as well. And in the peak stage, we see progression of the airspace disease with still persistent areas of ground glass opacity, but the airspace disease in these patients who progress becomes sort of the predominant pattern. And then in the late stage, we start to see what look like more fibrotic signs. So we'll see these areas of subpleural parenchymal bands. We'll see areas of traction bronchiectasis and areas of architectural distortion. So the ground glass opacities and the airspace opacities kind of start to regress a little bit, but now we're seeing more fibrotic appearance. So we see these very typical subpleural parenchymal bands. We see these areas of traction bronchiectasis and these areas of architectural distortion in the late stage. The other findings that have been described in the literature in the late stage is that the areas of consolidation and the ground glass opacities will decrease. And in the literature, they describe this as sort of the melting sugar sign. And this is kind of interesting in where the ground glass opacities in the consolidation, they actually, pardon me, will increase in the parenchymal extension. So we'll see it involving a larger area of lung, but the area will have decreased attenuation. So here's just an example that what we would call the melting sugar sign. So here's the patient on initial presentation, and we can see this area of ground glass opacity, and then as they evolve and improve, the area of involvement has increased, but the density has decreased. So this is just an example of what we call the tinted sign or the melting sugar sign. And same thing here. This area of airspace disease and sort of focal airspace disease and ground glass opacity is larger but less dense as the patient evolves. There have been some isolated reports of the development of significant Bolus disease with pneumothorax and pneumomediastinum in the late stage. Not really sure if this is actually secondary to the disease itself or whether this is secondary to ventilator-induced lung injury in this patient population. And this has actually been seen with higher frequency in younger patients. So here's just an example from our own institution. This was upon initial presentation, these sort of ground glass and consolidative changes. And 3 months later, this patient is presenting with these severe bolus changes, and we can see fibrotic changes with traction bronchiectasis and architectural distortion. But these are patients who have quite a severe course, and many of them do require mechanical ventilation. So we're not sure if this is actually just a sequelae of the barotrauma or a true reflection of the severity and damage caused by the COVID pneumonia, or a combination of both of them. But this is something that we do see in these patients with severe disease. There have been case reports of dendritiform pulmonary ossification seen in these areas of fibrosis. So this is just a case report in someone who had severe COVID pneumonia with fibrotic changes. And we can see the typical pattern here of dendritiform pulmonary ossification developing several months after the initial infection in these areas of fibrotic change. Some of the complications that we see developing in patients in sort of the subacute phase. So some of these patients will go on to develop ARDS. We know about the association with pulmonary embolism, superimposed bacterial or fungal pneumonia, and patients who develop associated cardiac disease with myocarditis and heart failure. So ARDS is typically seen in older patients. What we see are the typical ARDS findings, so non-cardiogenic pulmonary edema. These are often patients who need to go on to mechanical ventilation, and this is the most common reason for ICU admission and the main cause of mortality from COVID-19 pneumonia. So this was a patient, again, from our institution, a 40-year-old woman, 30 weeks pregnant and developing these severe areas of diffuse airspace consolidation and went on to develop ARDS and ended up having a prolonged ICU stay. Pulmonary embolism. There is a 5-fold higher incidence of PE in patients with COVID-19, and the incidence is estimated at around 17 to 35% in patients with COVID-19 pneumonia, and it is associated with a higher increased risk of overall death. So this is just an example, again, typical findings of COVID pneumonia, segmental pulmonary embolus here. So there is a higher association of pulmonary embolism in these patients. Superimposed pneumonia, so 10% of hospitalized patients will develop bacterial or fungal infection. And cardiac injury, up to between 12 and 20% of these patients will go on to develop some form of cardiac injury. And this is also another independent risk factor for in-hospital mortality. And there's often associated pericardial effusion in this patient group. So just to conclude, we'll talk a little bit now about the long-term imaging findings in COVID pneumonia. So there was a study looking at sort of the immediate short term, so sort of the 1 to 3 month period of these patients who were discharged with COVID pneumonia. And they imaged these patients at discharge, 1 week, 2 week, and 3 week follow-up. And the different findings that they saw were the ground glass opacities, which decreased over time but didn't resolve completely. And these sort of subpleural fibrous bands, again, were seen in a significant percentage of these patients at discharge. And that also decreased over time. And then other findings that were present that decreased over time were the architectural distortion, that's the green line, the orange line representing pleural thickening, and small associated pleural effusions. So really ground glass opacities and fibrous bands were seen at discharge, and both of those decreased significantly over a 3 week period of observation after the patients were discharged. If we look at the percentage of patients that had complete radiologic resolution at different time points, so patients who had imaging findings on presentation, at discharge, 8% of them had complete resolution of their imaging findings. And then at the 3 week period, up to over half of them actually had complete resolution of all radiological findings at 3 weeks after discharge. There was no distribution between male versus female in terms of the resolution of imaging findings. Not unexpectedly, younger patients were much more likely to have complete resolution of their imaging findings. And interestingly, the CT Severity Score at discharge was not a statistically significant determinant of whether or not the imaging findings would resolve completely in the sort of immediate post-discharge stage. So here's just a few examples. This is a single patient. This is the baseline scan showing some residual minimal ground glass opacity, these linear parenchymal bands. This is the patient 1 week out, 2 weeks out, and 3 weeks out with near complete resolution seen on the 3 week follow-up scan. Another group out of China looked at 114 patients with a diagnosis of severe COVID pneumonia clinically. And these patients were studied prospectively after discharge, and they were observed 17 days after discharge and then 175 days after discharge. So 35% of these patients did go on to develop fibrotic-like changes at the 6 month follow-up interval. And these again were the areas of traction bronchiectasis, these subpleural parenchymal bands, and these areas of honeycombing. And so here's just an example from our own institution of these subpleural parenchymal bands that we're seeing. This was the patient upon admission. This is a patient 4 months discharged, so some improvement, but these persistent subpleural parenchymal bands that are seen bilaterally, and then 10 months post-discharge, these are still persisting. You know, they've improved a little bit, but they're still here and they're still remaining. So we are seeing these sort of in the 6 to 12 month follow-up stage, that these do persist in these patients. Factors that predicted the persistence of these fibrotic changes, obviously it makes sense. These are disease severity markers. So these are seen more commonly in elderly patients, patients who had a prolonged hospital stay, patients who had ARDS, patients requiring non-mechanical ventilation. So these were patients all who had a higher likelihood of having these fibrotic-like changes on their 6 month follow-up examination. In terms of the clinical presentation, when we looked at these patients in their 6 month follow-up, 6% of them still had persistent clinical symptoms, the most common symptom being dry cough, 14% still having dyspnea on exertion, and 26% of patients 6 months follow-up still had abnormal pulmonary function tests, so abnormal diffusion tests. And these were seen much more frequently in those who had persistent fibrotic changes than in those who had no persistent fibrotic changes on 6 months follow-up. Another study looking at 103 patients who were imaged 3 months after follow-up, 20% of them had persistent parenchymal bands, 25% still had persistent ground glass opacities at 3 months out, 50% of them still had significant dyspnea on exertion, and 25% of them still had reduced diffusion capacity 3 months after discharge. And then the same group that looked at the 6-month follow-up group also looked at the patient population 1 year follow-up after severe COVID-19 pneumonia. And this was just published in July of 2021. So this is a recent article looking at the 1 year follow-up. So out of their patient population, they had 62 patients who had findings of lung sequelae on imaging at the 6-month follow-up, and 35 of them had fibrotic changes, so parenchymal bands, traction bronchiectasis, and honeycombing. 27 of them had lung parenchymal changes, but they didn't have fibrotic changes. So these were just areas of ground glass opacity that were persisting on the 6-month follow-up scan. And so they evaluated these patients again with CT chest and PFTs at 1 year. And they subdivided them into the fibrotic group versus the non-fibrotic group. And 100% of the patients who had fibrotic changes at 6 months had persistent fibrotic changes 1 year later on their follow-up CT. And about 3/4 of them had stable disease, and about 1/4 of them had slightly improved fibrotic change. But it seems like pretty much everybody who had fibrotic change at 6 months, that change persisted 1 year later. In the non-fibrotic group, so patients who just had areas of ground glass opacities, more than half of them had a complete resolution of all imaging findings. 22% of them had partial resolution, and only about 15% of them had stable findings between 6 months to 1 year follow-up. So here we just see examples from that article of these different patients. For example, the F0, F1, and F2 indicates the baseline, the 6 months, and the 1 year follow-up. So this was a patient who had ground glass abnormalities on their baseline scan, persistent ground glass opacities, but improvement at 6 months, and then complete resolution here 1 year later. As opposed to a patient over here, this patient had predominantly ground glass opacities. There were fibrotic changes seen here at 6 months out, and there are persistent fibrotic changes a year later with some areas of parenchymal improvement. Here's a patient 6 months out with fibrotic changes that persisted unchanged a year later. So these are actually 2 different patients. These aren't just the right and left lung of the patient. Each of these vertical columns represents a different patient, showing the different temporal evolution. Again, here's another patient with areas of consolidation and traction bronchiectasis, some fibrotic changes, and again, persisting really unchanged at the 1 year mark in this particular patient. If we look at the clinical presentation of these patients, again, all participants, a small percentage of these participants did have persistent clinical symptoms, and not unexpectedly, there was a higher percentage of symptomatic patients with fibrotic changes and a lower percentage in patients without fibrotic changes. If we look at the PFTs, the diffusion capacity, there were diffusion abnormalities in about 70% of all participants of mild diffusion. 7.5% had moderate diffusion abnormalities. And again, these were seen with much higher frequency in those who had fibrotic changes versus those who did not have fibrotic changes on their 1 year follow-up examination. If we look at the SARS imaging findings and kind of try to correlate the long-term impact by looking at the data from the SARS cases, the imaging findings from SARS pneumonia showed that there was some reversible fibrotic changes in the early convalescent stages, similar to what we were seeing in our literature, that you know, patients at discharge and then at 3 weeks or 3 month follow-up, some of the patients who had fibrotic changes did resolve. But there was a significant percentage that did have persistent fibrotic changes a year later in patients with SARS pneumonia. And they found that once the fibrotic changes were present 1 year out, these tended to persist and still be present on up to 15 years follow-up. So, you know, they're not the same disease, but I think we can extrapolate and say that the fact that we are seeing persistent fibrotic changes in a similar disease entity and 1 year follow-up, this may indicate that these fibrotic changes that we're seeing in the late stage are likely going to be irreversible in this patient population. So just to summarize, we've reviewed the imaging findings of COVID pneumonia and how they're classified and reported as either high incidence or typical. Then there's sort of the intermediate or the non-specific category, and the low incidence or negative for pneumonia classification. And this is how we tend to report at our institution. We either say it's typical, it's non-specific, or it's negative for pneumonia. There is the CORADS system, which was developed, and we have the CORADS stratification system, with 1 to 2 being a very low suspicion, 3 being indeterminate suspicion, and 4 and 5 being high level of suspicion for COVID infection based on the imaging findings. And that correlates quite well with when compared to the PCR positive or negative COVID test, with fairly good inter-observer agreement for the use of the CORADS system. We also looked at the CT Severity Score, which is using a cutoff value of around 20, can be used to predict mild versus severe clinical course in these patients in the acute setting. And we also reviewed some of the long-term imaging sequelae of COVID-19 pneumonia that we're starting to see being described in the literature. So about 35% in patients of severe illness will show these fibrotic changes at the 6-month point. And once we see these fibrotic changes at the 6-month point, these do persist up to 1 year in about 100% of these patients. And the associated fibrotic changes are associated with increased risk of prolonged clinical symptoms and impaired diffusion capacity on PFTs. And obviously, you know, there's more work and more time needed to see what these long-term sequelae will be in the years to come, whether these changes will be permanent, whether they will be progressive, and whether there will be some sort of reversible component. But preliminary data is kind of suggesting that at the 1-year follow-up examination, any fibrotic changes that we see are likely to be permanent on imaging. So with that, I thank you, and I will see if there's any questions.
So thank you very much, Dr. Taylor, for your excellent presentation. I have a couple questions here. In patients with severe COVID findings or a high chest severity score, how do we have to follow them up? Just chest x-rays, or do we have to go further with CT, and how often do we need to scan the patients?
Yeah, that's a good question. I don't believe there's any current recommendations on the radiographic findings and how these patients should be followed. At our institution, at least, basically any follow-up is based on their clinical presentation. So, you know, if the patient is clinically stable or improving, typically we don't tend to follow them with imaging. Whereas if the clinician finds that their clinical status is worsening, they will send them. And it's really a mix. Some clinicians are sending them for radiographs, and some of them are sending them for CT. I personally believe that there's a lot more information to be obtained from CT, and I would recommend following them with CT, because it's really, you want to be looking for these subtle ground glass opacities and these fibrotic changes. And I think you can't really appreciate them in terms of the temporal evolution very well just on plain film. So again, my my personal experience is that these patients should be followed radiographically only if they're deteriorating clinically, and they should be followed with a non-contrast CT.
Okay. When comparing CORADS with the previous RSNA classification system, are we getting additional information or achieving better diagnostic performance?
They did compare the CORADS to the classification system from the RSNA classification, and they were found to perform very similarly. So I'm not actually sure that CORADS. I think CORADS is useful to the clinicians because they understand the RADS system, and it's a very nice way to communicate because they understand what a CORADS 5 means versus a CORADS 1. The same way the clinicians understand what a CORADS or a BI-RADS 5 means versus a BI-RADS 1. So I think it's maybe a more elegant communication tool, but I don't believe it performs any better in terms of conveying the level of clinical suspicion than just using the typical versus indeterminate versus negative sort of 3-point classification system.
Okay, I have a question here. When do we have to use CORADS score? Any patient with respiratory symptoms and suspicion of infection disease, or only in patients with COVID suspicious infection?
So we personally don't use CORADS at our institution. It was designed to be used on patients who are presenting with clinical symptoms and a suspected diagnosis of COVID. And I believe the CORADS system was really developed at the beginning of the pandemic when there was a significantly longer turnaround time for the PCR test. So I know I had a COVID test at the very beginning of the pandemic, and it took me 7 days to get my results. And I had one a few weeks ago, and I had a results in 4 hours. So I think the CORADS was much more useful early on in the pandemic when testing wasn't as fast and wasn't as easily available, and it was a really good way for the clinicians to kind of risk stratify these patients before the PCR test had come back, because it was taking days in a lot of cases. Now that the rapid COVID tests are much more available, I think the CORADS is an interesting system and maybe could be useful as a research tool. But I think its clinical implications and clinical use is less important than it was at the beginning of the pandemic.
Okay, Jana, so thank you very much once again. Was a great talk, very useful, and I hope to see you soon.
Great, thank you so much for the invitation. It was an honor to be invited today, and I wish you all the best. It's great to see you again.
Okay.
All right.
Thank you, everyone. A todos. Gracias a Kebarco y G por el apoyo de esta conferencia, y será al final de este mes que volvamos a tener la oportunidad de presentar algunas conferencias. Muchas gracias a todos.
Thank you.